a preoperative platelet transfusion algorithm for patients with cirrhosis and hepatocellular carcinoma undergoing laparoscopic microwave ablation. Of the many complications that can result from chronic liver disease, thrombocytopenia is relatively common and can have significant clinical effects. With coagulopathy and transfusion as significant risk factors for postoperative morbidity, it is important to identify thresholds and determine appropriate preoperative transfusion guidelines. Minimally invasive microwave ablation has become a key component in the treatment algorithm for hepatocellular carcinoma. Demonstrated to be safe and effective even in patients with cirrhosis, it can stall tumor progression, decrease transplant waitlist dropout, and be used in a curative fashion. With many patients with cirrhosis and HCC undergoing minimally invasive microwave ablation, it is important to identify appropriate criteria for platelet transfusion to ideally avoid intraoperative and postoperative bleeding risk. As such, this study aims to determine an algorithm for preoperative platelet transfusion criteria. A retrospective review of all patients who underwent minimally invasive microwave ablation were identified between 2007 and 2019 at a single center tertiary institution. Inclusion criteria were adults with HCC and cirrhosis and complete laboratory data. The primary outcome assessed was bleeding risk. This was defined as any transfusion received intraoperatively or postoperatively, or a postoperative bleeding event. Postoperative bleeding event was defined as a downtrending hemoglobin or platelet count that required a medical or surgical intervention. Chart abstraction was used to collect the listed variables. There were 433 patients with HCC and cirrhosis who underwent minimally invasive microwave ablation, of which 353 had complete laboratory values and were included. Patients with a bleeding event were separated from the cohort. There were 60 patients identified, some of which had multiple transfusions. This is either an intraoperative platelet transfusion, intraoperative red blood cell transfusion, postoperative platelets, postoperative red blood cells, or a postoperative bleeding event. This bleeding cohort was compared to the non-bleeding cohort of 293 patients. There were comparable rates of concomitant procedures except for laparoscopic cholecystectomy, which was slightly higher in the bleeding cohort. The BCLC staging was comparable between cohorts, with the same amount of stage 0 and stage A cases and slightly more stage B cases in the bleeding cohort. There were no difference in the number of tumors ablated. There was additionally no difference in 30-day readmission rates. Finally, there was no difference in the size of the largest lesion ablated as well. Bleeding risk was evaluated through a bivariate analysis of statistically and clinically significant variables that included demographics, platelet count, and hemoglobin. 2 logistic regression models were created to predict bleeding risk and identify patients who would benefit from a preoperative platelet transfusion. The first model was used to identify high-risk patients with both thrombocytopenia and anemia. The model identified bleeding risks associated with a platelet count less than 60,000 and a hemoglobin less than 10. The second model sought to identify high-risk patients with thrombocytopenia but without anemia. This model identified bleeding risk in patients with a platelet count less than 30 and a hemoglobin greater than 10. Patients with HCC and cirrhosis have increased risk of bleeding complications after invasive procedures due to thrombocytopenia and hematopoietic abnormalities associated with malignancy. With coagulopathy and transfusion as significant risk factors for postoperative morbidity, prophylactic identification and subsequent treatment of these high-risk patients is beneficial. This study establishes a predictive algorithm using preoperative lab values to identify patients at high risk of bleeding complications who should be considered for preoperative transfusions. Platelet count and hemoglobin count both contribute to determining who may benefit. As our bleeding and non-bleeding cohorts had comparable BCLC staging, tumor size, and number of tumors ablated, we assumed that the bleeding was not secondary to differences in minimally invasive techniques. We determined from a retrospective assessment that patients with either a platelet count less than 60 and a hemoglobin less than 10, or a platelet count less than 30 and a hemoglobin greater than 10 may benefit from a preoperative transfusion. We recommend transfusing 2 bags of platelets or about a 10-pack preoperatively when meeting these guidelines. There are several limitations present in this study. To identify bleeding risk, any intraoperative or postoperative transfusion or postoperative bleeding event was included as an event. Some of these transfusions were given for asymptomatic lab values, while others were given to symptomatic patients. Thus, not all bleeding events may have been clinically significant. Additionally, our assumption that bleeding risk was primarily based on preoperative lab values because the two cohorts were fairly comparable is just an assumption. There were more BCLC stage B patients in the bleeding cohort than the non-bleeding cohort, which could have an effect on bleeding risk. However, there were no differences in tumor size or number of tumors ablated. Further, we did not take into account MELD score, Child-Pugh score, or other comorbidities which may have clinical effects as well. Finally, this was a retrospective analysis, and thus there is significant bias present. The ability to predict bleeding risk in patients with cirrhosis and HCC may help avoid bleeding complications after minimally invasive microwave ablation. Our algorithm recommends consideration of preoperative transfusions for either a platelet count less than 60 with a hemoglobin less than 10, or a platelet count less than 30 and a hemoglobin greater than 10. This study currently is being prospectively validated and ultimately may be beneficial in assessment of novel therapies for platelet-based clinical treatment in liver disease. Thank you very much.